Shiva, can you hear us?
Bharat, very well.
Yeah, I think we can start this session.
Sure.
And I have Martin Box with me as a co-moderator. And then we have a panel of Thanapoulos from Greece, Ulrich Herberg from Germany, and Dr. Mood from Malaysia. And Shaq is the facilitator. So
Okay.
you can go ahead, introduce the case, and we have excellent audience here.
Great. Bharat, it was nice to come for the second session of the transmission again to the Congress Theatre. We have about 4 cases lined up for the second session. The first patient will be a percutaneous pulmonary valve implantation in a rasterly conduit with a melody valve. One of my colleague will give the clinical presentation. Can you show the PowerPoint, please?
So for this case, this is a 25-year-old male, a known case of tetralogy of Fallot with infundibular valvar PS. At 8 years of age in 2004 October, he underwent a transannular patch repair along with VSD closure with a Gore-Tex patch. He had a stormy post-operative course where he required a more than 1 month of ICU stay with bilateral pleural effusions requiring pleurodesis, and on the 2D echo at that time showed a residual VSD with partial dehiscence of the VSD patch. There was free severe PR. During the post-op course in around November 2004, he underwent a redo surgery with a surgical closure of the residual VSD. In order to arrest the free PR, he underwent a 19 pulmonary homograft which was inserted with a proximal bovine pericardial patch in RVOT. On follow-up, he was identified to have progressive conduit stenosis and effort intolerance. He was on heart failure medications with ramipril, and also in view of palpitations with Holter showing some ectopics, he was on metoprolol for the same. On examination, he is an obese with weight of around 96 kg. There's a grade 3/6 ejection systolic murmur in the left upper tunnel border. The chest X-ray shows situs solitis levocardia. There's cardiomegaly with RV apex and a left aortic arch. ECG is suggestive of a right bundle branch block with QRS duration around 160 milliseconds and a normal QRS axis. The 2D echo showed there's no residual VSD. The conduit gradient as shown in the image was around 68 to 72 millimeters of mercury. There was mild TR with RVSP corroborative of 72 plus RA. There was dilated RV with mild RV systolic dysfunction and a good LV systolic function. CT pulmonary angiogram was done to evaluate for the anatomy. There was a conduit stenosis which measured around 16 into 13 millimeters, as we can see in the MPR. Then the coronary proximity to the conduit was also assessed, which showed that there was significant distance between the conduit and the coronary, around measuring 3 centimeters to 5 centimeters. This is the 3D volume rendering done using vMersive software. Sorry. It's not playing. vMersive software where we are slicing the heart from the cranial end, and we can see the right ventricular outflow tract and the branch PAs. This is the dilated branch PS as we are visualizing it, and the conduit. This is a holo heart model showing narrowed RVOT, which is seen in lateral view also. And here that is the lateral view where we are seeing the conduit stenosed. We are also planning to use a melody valve, which is a CP stent mounted on a bovine jugular vein. When a 34 millimeter CP stent is mounted using this model, which we are then dilating up to 22 millimeter, we can also estimate the foreshortening we would expect in this valve.
So, Dr. Bharat, this is a pulmonary homograft which is stenotic now. The hemodynamics that we got was the right atrial mean pressure was quite high. I think in the PowerPoint presentation you would have observed, this patient has been with significant heart failure for the last 2 to 3 years and is being treated by the primary care cardiologist with some beta blocker and ACE inhibitors. He has some amount of ventricular dysfunction. Today, the right atrial mean pressure was almost touching 20 millimeters of mercury. The right ventricular pressure was 92 millimeters of mercury, and the pulmonary valve gradient was more than 50. So there was marked elevation of the RV systolic pressure. Show the fluoroscopic screen now. So what we have done till now, We have taken a right femoral venous catheter, left femoral venous catheter, and a left femoral arterial catheter. Through the right femoral venous catheter, we have put in a Lunderquist wire through the pulmonary valve into the left pulmonary artery. Through the left venous catheter, a pigtail has gone into the outflow tract. And through the arterial catheter, a Judkins left coronary catheter has hooked into the left coronary. I have wired the left coronary with a coronary wire so that the catheter does not get disengaged. The catheter will stay at the ostia. So now I'll be ready to take questions. The hemodynamics show more than 50 millimeters RVOT gradient and a significantly elevated RA pressure indicative of systemic venous congestion and right atrial hypertension.
So any questions or comments?
I think we need to look at some angiograms at the moment before we...
So,
Shaq, nice to hear your voice.
So Shiva, the thing is that have you done any angiograms in the right ventricular outflow tract, either in the main pulmonary artery or in the right ventricle?
I'm just going to make it. This is the first angiogram that's going to be shot. I'm now pulling out the pigtail catheter to come into the target zone. So this is the target zone. I have hooked the left coronary artery, and I have the coronary guide wire going deep inside the left. You are ready for 25, 50?
Shiva, the question is it your usual routine practice to keep a coronary guide wire there?
Whenever we dilate a balloon across the right ventricular outflow tract, that right ventricular outflow tract balloon distorts the aortic root a little bit, and the aortic root, the distorted aortic root just disengages the left coronary. So with the full balloon, when I inflate and then subsequently try to shoot the left coronary, very often it will be just going into the aortic root and not engaged into the coronary at all. So I'll just show you one picture, disengage that injection. So now I am going to show one picture. So now I have engaged the coronary. I have this is the coronary catheter. This coronary catheter cannot move because the guide wire is holding it in place. The guide wire is now entering the left anterior descending coronary artery, and it ensures that I will be able to consistently get a coronary injection. What has been your practice, Dr. Bharat?
We usually don't keep a wire, although we keep the catheter engaged. And I don't disagree with you that once in a while when you are doing balloon interrogation, it does get displaced sometimes. So if it does, then probably we may consider putting in a wire, but not as a routine.
Okay. So basically now if I see, there is a tight narrowing, and the coronary guide wire is far below, and in the same injection after some time I had injected the left coronary as well. So we are seeing the left anterior going anteriorly, circumflex going posteriorly. So now the reason for keeping the marker on the Lunderquist was to make a measurement of the angiographic picture, but I have done a lot of this homework on the CT itself. So our plan is to go for a 22 millimeter ZMED balloon, dilate the conduit, interrogate the conduit and check the coronary, see the yielding of the valve, and then decide about whether we have to use a high pressure balloon or whether we are good to go for pre-stenting.
Shiva, let me just ask somebody, or I'll pick on somebody, for that guide wire positioning in the left coronary artery, how important that is.
We don't use that regularly. We don't use that. We just put a balloon size and inject in either directly into the coronary in case we do aortogram and settle, and there's away from that we continue our procedure.
Tony?
Yeah, I mean, I have to say it wouldn't be our routine practice to do that, but it seems reasonable what she was suggested.
Because once you get compression, it's too late, isn't it?
The problem, actually, there were a lot of ectopics that were induced when I was crossing the right ventricular outflow tract. Now the ectopics have sort of little bit settled out.
But
so
usually, Shiva, the CT scan gives you a clue as to whether the coronary artery is
Yeah,
going
but
to be.
Shaq, what he was saying, he was not worried about the distance of the coronary. He was wanting the catheter position to be stable. It happens many times that when you are balloon interrogating the
Yeah,
right
it
ventricular
pops.
outflow tract, it pops.
Yeah, yeah.
And that is why he said that he wanted to keep the wire.
Yeah, okay, all right.
so
Okay, go ahead, Shiva.
thanks.
Oh,
thanks
there is
for,
one more comment. Go ahead.
Thanks,
Shiva,
Bharat, for making it clear.
This
In
is
fact,
Sham from IJN.
Hi.
From the CT scan and also from angiogram, you can notice there's some calcification. But I'm not sure. Is that will influence your decision? One. I think second is to respond to Bharat's comment. If patient has very severe calcification, I would actually keep the wire in. This patient has not I think the calcification is not that obvious, then probably wire is not necessary.
Here, the calcification is anterior by looks of it,
Yes,
isn't it? That's
yes.
all localized. It's not extensive all the way around,
I am
where it
inflating.
becomes unpredictable.
I am inflating the balloon. So now I am deflating it.
Sorry, Shiva, which balloon is that?
That is a
Z-Med.
22 into 5 Z-Med. Is it 22 into 5 or 22 into 4? 22 into 4 Z-Med.
Okay.
So now let me run that picture for you. So this is the Z-Med balloon. The Z-Med balloon has still retaining a waist. I have, what is the burst pressure of this Z-Med balloon? 4. I have gone already to 4. Okay, so about the question of Hisham, the calcification was more in the right ventricular outflow tract below the level of the narrowing. You can appreciate in this view, rather than at the level of the conduit narrowing. So I was not very concerned. I'll just make another inflation now.
So, Shiva, whilst you're doing that, let me just pick on, Matt. Z-Med balloon or other non-compliant balloon versus, broken the glass completely. So that was a compliant glass.
That was
So,
non-compliant.
Z-Med balloon versus Atlas or things like balloons like that.
Yeah, I mean, I think you want to start with
Set
a
it.
relatively soft balloon because you want to
Set it.
see how compliant the area is, whether you're going to get a waste. Because whatever you put this on is going to be a relatively low pressure balloon, the stent in the first place. You'll get a waste with a stent on this. I just wonder whether this balloon is a little bit undersized compared to the distal pulmonary artery and whether a slightly bigger balloon might give you a sort of more definition of the size of the MPA.
The other point, again, it's not relevant here, but if you've got a lot of calcification, then it's much better to have a balloon that is unlikely to rupture transversely, so something like an Atlas, whereas Z-Med, Taishak, any of those can rupture unpredictably, and if they're transverse ruptures, then you've got a bigger problem to deal with.
Okay, about the question of going for a larger balloon, this was a 19 millimeter conduit and I'm going for a 22 millimeter Z-Med balloon. I don't want to go any further larger than this.
Unless you have a covered stent in place.
Correct. And second thing is, my intention is to use a melody valve, which is going to be 22 millimeter. And so there is no big advantage by dilating it much larger than this. Show me the last angiogram, the last balloon inflation sequence. Last balloon inflation sequence. Yeah. So this is almost, we can see that a 22 millimeter has fully opened out. Now let me see what is the angiographic picture. Are we ready for an angiogram now? The pigtail catheter has come back. but
Shiva,
anyway.
Martin has a question for you.
Yep. Ready?
Yeah, hi. My question is, I've done most of these in a biplane lab where I can see the coronaries in two views. Do you often find yourself having to repeat the coronary angiogram with your balloon sizing if you're worried more about the coronary? Or do you always stay with one view?
It is not staying with one view by choice. Basically, we have only single plane lab, and so here we are forced to use one view. If I have to shift, then I have to like come back and make another angiography. But in this particular patient on the CT, we have found that the working plane is on lateral view, and hence now we are happy. Can you show the valve here? See, basically what I am planning to do is, show that balloon inflation once again. Show that balloon inflation, this last balloon inflation. In here, the 22 millimeter balloon has almost fully opened, and hence I am happy to take a direct ensemble with a pre-stent. I want a 39 millimeter Zephyr, large.
So, Shiva, just show the angiogram first,
Yep. Show the angiogram.
and not the balloon, but the subsequent one.
Show the angiogram.
Next one.
Show the.
The one you've just, yeah, that one. What are the measurements of that, not just the narrow area, but above and below?
Actually, we have not measured right now, but I can tell somebody to. Can some of you work on? I'll get a better quality angiogram, Shaq, because this is now in the right ventricle. I'll try to get you if you are interested.
And with that balloon inflation, did RV pressure change at all?
I will now disconnect the injector, and I will see the pressure. Get me a pressure line here. Yep. Open this pressure, please. This is right ventricular pressure. Open it. Okay. Show the hemodynamics big. RV pressure is not changing much, Bharat. It is almost 90, yeah,
Okay.
85 to 90. Are you able to see the screen?
Yeah, we can see.
Yeah, around
We can see
85
it
to
very
90.
well.
Nothing very, I think there is a lot of recoil.
You've got them
Yeah.
on two different scales, which
Yeah.
is confusing my brain.
So-
okay, show both in 200 scales.
It's 90 to 180, I think.
Yeah, no, we'll show that now properly.
No,
Yeah, but
Shiva, while you are making the measurements, my question to you is that you are not able to open this narrowing even with a Z-med. Now you are going to mount your melody on a bib. I don't think you will get that much of a pressure on bib. So then what is your plan? I mean, if you are not able to take care of that narrowing,
the
why are
AP
you
view?
doing it in one step? Why not create a landing zone? Be satisfied with a landing zone by putting either a covered stent or a bare metal if there is not much of calcium, and then go ahead and put in a valve. Why do it in one step?
My plan was to get the pulmonary valve in position and then dilate it with a 22 millimeter atlas. The melody,
Yeah, but
and if it doesn't expand,
it already expanded. Show that 22 millimeter the Z-med balloon, the final balloon, the previous.
can we ask the audience as to what would be their choice?
Now see this
Would
picture.
it be creating a landing zone first and then putting in a valve, or the other way around?
but also whilst we're asking the audience, if you'd measure above and below, you gave a measurement of the narrow area, but also on the angiogram above and below.
We are getting it, Shaq. Now you see that I am showing that picture again. This is a 22 millimeter balloon. You see that almost the narrow portion has increased to
All right, measure the balloon then. Is it 22 millimeters?
Yeah. Can you make all the measurements? Number one is this balloon and the previous one itself. The previous one that you started. Can you show that? The previous one. I think after this. After this. The last RVOT angiogram that we did. I think I'll make a fresh angiogram, Shaq. Now I am in a beautiful position. Go to lateral view. Get me that marker picture once again.
Shiva?
Yes.
Asad Khouri, Rambam, Haifa. I would go with this case with pre-stenting and see if I can abolish the RV pressure before putting a valve in there, okay? I think, at least in my practice, this is what I would do.
Because it's a cheaper way of finding out if it's going to dilate, isn't it, than putting a
Okay.
valve.
Ready for angiogram? give
And also, Shaq, it's not a great idea to
25 or
put in a
50.
melody and then subject it to, it's a robust valve most of the time.
Yeah, but you're
nothing
taking
happens.
your chance, aren't
And
you?
if you have to do it, you may do it. But in this case, when you have a choice, I think it may be a good idea to
Yeah.
get rid of the waste.
Anybody else want to volunteer?
22 into 4
First,
Atlas gold.
implant the covered stent, then dilate with Atlas balloon, then do a valve is better for me.
Sharon?
25 into 25 ml 15 rate.
I have to agree. I would create a good landing zone. Also, for the longevity
Ready?
of the valve afterwards, it's much better to not have stenosis before you implant it.
Okay. Now make a measurement on this. No. Make a measurement on this.
So, Shiva, just out of interest, what is stopping you from stenting and then following it up with melody or whatever valve?
I'm going to definitely stent Shaq, but it's a one-step procedure. I'm not
Oh, so you're
filling it-
putting a stent on the outside of the
Correct.
melody. Oh, I missed that bit.
I want a 22 into 4 Atlas gold balloon. Can you call somebody Atlas gold? I want an Atlas gold 22 into 4 Atlas gold New York.
So whoever is measuring, ask them to measure above and below as well.
Above and below also. Right ventricle also measure. Main pulmonary artery also measure.
Basil.
You have
Can you measure the main pulmonary artery, the narrow portion, right ventricular outflow tract, everything now measure? 22 into 4. That's,
Shiva,
yes.
do you have any other projection?
No, he's working on single plane and he's only doing lateral angios.
22 into 4 Atlas gold.
So X2 is 34, and then measure above as well in the pulmonary artery.
Shiva, my
22
question to
into
you
4
is
New
that
York.
you have a
don't want
19
old.
millimeter pulmonary homograft,
You don't have.
which is how many years old now?
This is about 15 years.
Yeah, and you want to use a 22 millimeter Atlas to get rid of that waste. Why not pre-stent with a covered stent and then do it for the sake of safety?
Just 1 second. I'm just trying to get the balloon. 22 into 4 Atlas.
There's another reason for doing
22 is
pre-stenting, follow it later by valve rather than in one go. What's that reason, Matt?
Get me the 22, this one, the
Well, I mean, I guess there's a couple of things. You've got some calcium, so you've got a little bit of a risk of rupture, although if you've got a covered stent on the outside, you should be all right. The second one is that the PA, if you measure the distal PA underneath the central line, it's much bigger than a 22 balloon. Just by eyeballing it, it's going to be about 30. So your risk of forward displacement is going to be not insignificant. I'd probably rather, or downwards, I'd rather embolize a stent than an expensive valve. I have to say, I think I'd probably be going for something a lot bigger than a melody in this case.
Yep, I agree. Any other volunteers for comments? Because the options are Melody, Sapien, MyVal. Those are the main balloon expandable options here, aren't they? Tony?
I just wanted to ask Shiva if the fact that the patient's 96 kilos, whether that plays into his thinking about ultimate valve size that he wants to implant.
This is more like an American patient, isn't it, rather than an Indian patient? But yes, very important factor, 96 kilograms.
even though he's 94 and he will be better off with a larger valve, since the previous homograft is 19, I feel that a maximum of 22 and not more than that, and that makes it make us choose a valve that goes up to say 22 millimeters or at the maximum 22 to 23 millimeters. So that is one of the reasons why we decided that even with the covered stent, if I stretch it out and beyond the covered stent, because the remaining portions are all slightly larger. So in some places, if there is a crack and that crack extends into the distal normal pulmonary artery, then we
There will be some endo leak.
Yes.
Yeah, we agree with that.
Yeah.
Yeah.
Shiva, let me ask you a simple question.
Yeah.
What is the distal MPA measurement?
Distal MPA, can you show the measurements that you, sometime before somebody showed that measurement? Show that?
He hasn't done it, I don't think.
No, they showed, Shaq. Show the,
Missed it then.
yeah, distal MPA. No,
Distal MPA,
Distal
I
MPA.
didn't see it.
distal MPA is not measured.
That's why I was asking the subtle question. Basil,
No, now you see it. It is something
Okay.
like 26 point, I mean, big, large.
it's bigger than 26, isn't it? Yeah, that was the point Matt was making as well. Basil, go on.
I wonder, as I have understood that in this case, the prestent is going to be completely in the RVOT?
It's where the narrow area is, which is between RVOT and MPA, yeah.
An MPA, not completely in RVOT.
No, because the RVOT, if you look at the pictures,
Yes.
is 34.
Okay. The other thing is that once you put a prestent, I would say that it's rather to put a balloon expandable valve.
Yeah. Yep, good. Which one?
Which one?
Basil.
Melody.
Diameter.
What is the diameter? I was not here now.
That's why I was
Up to
testing you.
23, I was going to put.
It's a 19 homograft, which is ballooned up to 22, and there's still a stenosis there of about 19.
Melody for sure.
Okay. Now that's a different balloon. It's, I think, Atlas, is it?
Yeah, it's Atlas. It's a 22x4 Atlas. 22x2 Atlas.
22.
It's certainly squeezing the pigtail nicely.
Because it's not a 22x4, it's either milking forward or milking.
Yeah.
Give a pull. That's it. Don't pull further. Don't pull.
Yeah, use the pigtail as a landing area. Oh,
Okay, fluorostore that.
It would seem without a stent in place, you're going to get a lot of recoil regardless before your pre-stent.
Yeah, so I am the 22 ZMED at 4 atmospheres was able to reasonably open out the entire. I forgot to tell one thing. The distal pulmonary artery pressure, while RV was 80, the distal pulmonary artery was around 60. I'm sure once I put in the valve, it's going to be getting red. Show me the picture here. I want the Zephyr 39.
what was the distance?
Shiva, distal pulmonary artery pressure was 60, you said?
Yes,
60?
60. Maybe some amount of contrast and all, Bharat.
But 60 is
Well,
quite
that's-
high for contrast.
Yeah. See, the proximal RV was 80. But the original hemodynamics was the PA pressure distal was 40 systolic with a RV systolic pressure of 94. And then once we dilated, the RV pressure was 80 with the distal PA pressure of 60 and PA diastolic of around 18. So now, are you able to see the?
Yeah. Whilst you're doing that, the pressure doesn't add up.
Pressure is, it was 80 in the right ventricle. It was around
Yeah, that's okay.
60 in the pulmonary artery.
That's not okay.
I think it is possibly, now I'm in the distal pulmonary artery. I will now connect it to pressure once again. The pressures are possibly up due to some amount of contrast. Let me see now. This is now direct from the pulmonary artery. Show the pressure big. Pressures big screen. Pressures big screen. Yeah. So now distal pulmonary artery pressure is 40.
That makes a bit more sense.
Okay.
Yeah, that's right.
I'll make one angiogram at this point. This is now right ventricle. It's around 60. That's post-ectopic. Wait, I'll wait till it settles. Yeah, it's touching 60 line. Now, one angiogram on this right ventricle once again.
Oh, you've done something,
Yeah,
haven't you?
I
You've
think
done
he has
a
used the
atlas,
high
so
pressure
yeah.
atlas. So it may be a good idea to do one angio before you proceed.
It was a rubbish balloon, but yeah, go ahead.
It was not long. I wanted a 22 into 4, but unfortunately we had a 22 into 2. So I
Yeah,
had to.
yeah.
That was the time when I was losing some of the questions, and I was trying to ask my team members for the 4 centimeter balloon. Then I realized that it's not in shelf. I'm filling my injector. Yeah. Give an angiogram.
I'm still trying to, you do that, but I'm still trying to work out the rationale for putting the melody and the pre-stenting all in one go, as opposed to pre-stenting and following it up. Because you want to be secure that the stent is in place and has done something, I think. Or am I being stupid?
No, Shaq, I totally agree. The only time at which I
No,
take
it's all
this-
right. Shiva, I was asking the audience.
No, I'm telling my logic. In patients where the calcium is not too much and the compliance of the lesion is quite good, I try to go for one-step deployment. The one-step deployment makes it procedurally very simple. Now, when I do a separate stent angioplasty, will you keep flushing there? Yeah, keep flushing.
Siva, if you have a significant residual waste after you do this combination stent and melody valve, do you have any hesitation about going high pressure in a new valve, like let's say to 14 or 16 atmospheres to try to eliminate the waste?
I have done it with Atlas of the same size, the same 22.
No, but don't you have concern, Shiva, that you might traumatize the leaflets of the pulmonary valve?
It doesn't hurt at all, Bharat. I have done it some 7-8 times.
Okay.
It doesn't hurt the valve at all. It's a very long pillar valve. Unlike the sapien valve, the melody valve is a very, very, very long pillar. So right now I have to convert it into a long sheath. So what I'm going to do is, this is what? Saline? Dilator? Which one? Aren't you ready? Yeah, shoot. Okay. There is some amount of, opening of the conduit. So what I'm going to do now is change my groin sheath into a 20, this is a 22 or 24? Okay, 24 short hook sheath. There are some people who will take melody valve directly in the groin, but I tend to go with sheath. So this is
Any particular reason, Shiva, for that?
about
Going with a short sheath because, again, some resource being spent.
yeah, but the
Bharat,
I protect the ensemble's carrot and the proximal sleeves.
Okay.
So you're worried about the short sheath. He's using a pre-stent and melody in one go.
Yeah, that is also another cost-saving strategy. So Bharat and me, we will have sort of similar strategies to cost, like save. Actually, this one-step deployment is my preferred strategy if the lesion is very compliant. In this particular case, I would rather say it's very compliant.
Shiva, just simple question.
Yep.
From developing country, because we have very limited resources. One is the indication of having the short sheath. Second, does it really matter for you to park the wire in the right pulmonary artery or left pulmonary artery?
Okay, in this particular patient, since the pulmonary artery was the conduit was in line with the main pulmonary artery, left pulmonary artery, I decided to go for the left. About the using the short cook sheath, it makes it easier for me. I have got a figure of 8 stitch that I'm going to put in the groin at the end of the procedure, and it will be easier for me to put the figure of 8 if I take out the entire ensemble and only have the cook sheath, and it's easier for me.
Why don't you use ProGlide?
That's more expensive, Shaq. It's for United Kingdom, Evelina Children's. Now, are you ready? 15 at 15?
Use 2 ProGlides then.
15 at 15.
Can you tell us again what your pre-stent is?
A pre-stent is over the melody. It's a 39 millimeter XL stent. You are ready?
Which one? Zephyr or
Zephyr.
what?
Yeah, which
It's a Zephyr extra
okay.
large. It's something similar to Andra.
Okay. What do you know what it's made of?
I think you don't have contrast. You have to load contrast. So, in order to make, I will make a hand angiogram in this place. I am exactly on that place. So, while they are loading the contrast, I will inflate the inner balloon and keep myself ready. Unsheath.
Any questions? Any other questions from the audience? Or comments?
Yes. Where's the valve? Inside the stent. So the position of the valve inside the stent. We can't see it.
Oh, right. Shiva, did you?
I want to know.
I
where it is.
will show the stent. Just keep watching. Okay, I'm now doing cine. You see something protruding on either side of the melody?
Yeah.
It's a 34 millimeter CP stent in the melody valve, and there is a 39 millimeter Zephyr stent. Now, can you see about 3 millimeters on either side?
Yeah.
Yeah.
So now I have peeled back the sheath, and I'm making a side arm sheath injection. So my sheath is exposed. I'm now going to go for the inner balloon inflation alone.
Where's your other pigtail?
Pigtail is now in the right ventricular outflow tract, just below. What is the burst pressure of this inner balloon?
So you could do the angiograms through that.
Yeah, we are loading contrast. So is it 4.5? Okay. So now I'm going to make the angiogram.
And what's the other catheter now in the pulmonary artery?
Left coronary artery catheter that is lying with the coronary wire. That's coming from the aorta.
Yeah, okay.
One is retrograde.
Oh, right, that one, yes.
Yeah,
And the pigtail is just below, isn't it?
Correct. Now I'm
So
going
you
to
could
make.
you could get better angiograms from the pigtail then.
Yeah, we are setting it up. Now can we give 20 at 15?
He's a little too distal.
That's the coronary artery. Are you
That's
ready?
not compressed.
Yeah, you are ready? Shoot. Okay, my position seems to be okay.
Okay, Shiva, Kevin's just arrived. I'm going to ask him what he thinks now.
Maybe back a little bit. I
Yeah.
think just about 5-10 millimeters, just a center more.
I did it now, Kevin. Just give a slight pull. Yeah. Till the number.
Get the pigtail a little back, Shiva.
That's it.
Don't pull further.
Not checking.
So what is the burst of the outer? 4, right?
Oh, for 22, it's about 3.5, I think, isn't it?
Dr. Shack says that it is 3.5. Check. Is it 4 or 3.5? Outer is only 3. Okay.
Oh, there
so
you go.
outer
It's
is 3,
even
then
less.
I have already gone. So now I am deflating. I'm waiting for the pressures to build up. I'll make one coronary angiogram now as the coronaries are okay. See, Bharat, this is a distinct advantage. I will not move. The left coronary catheter will not move at all, and it will keep on giving me continuous angiograms.
I agree with you, Shiva, but many times, even without a wire,
Yeah.
it's not every time that it moves, but I take your point on that, that if wire is there, it remains rock steady.
Yeah.
Agreed.
Yeah. So now I'm going to, I have deflated the entire inner balloon. So now at this point, what I'm going to do is consolidate my outer balloon fully. So I'm going for just an outer balloon dilatation alone, because this gives even better inflation. So I'm partly inflating. Now tell me whether I'm going to 4. Huh? 4? 4. So I'm deflating.
When you deflate, I would film it because you want to see the. Oh, too late.
Okay,
Want
to
to see
see
the
the recoil,
recoil,
no?
but-
I will
Yeah, yeah.
make a measurement. I will put in a marker pigtail now inside, and I will get you a measurement.
Yeah, you're too quick, Shiva.
Okay, so now we are taking the ensemble out. Hold it. Thank you. Get me the marker pigtail ready. I'll flush the 24 French short sheet. Okay, marker pigtail on this.
So, irrespective of hemodynamics, Sharon,
you the
do you get rid of that waste?
I'll give you the hemodynamics. Just I have the right ventricle catheter ready.
Yeah.
I'll get you the
Irres-
pulmonary artery and then give you both together.
Shiva, I was just asking Sharon, irrespective of the hemodynamics, do you get rid of that waste?
Yes, I would get rid of the waste. And in fact, I was going to say that we're talking about the fact that it's a 19 millimeter homograph, but I don't think it matters so much because you really need to go according to the diameter of the main pulmonary artery, which is much larger. So I think that this person could use a larger conduit.
Okay.
So what would be your limit? I mean, I want to ask, what would be the limit? 96 kg, big person. How far can you go from 19 millimeters?
And I think every person, we often see that the homographs dilate very nicely over time. So according to the diameter that you see in your main pulmonary artery, I think is how big you can go. So if this person has a 26 millimeter pulmonary artery, maybe we could have put in a 26 millimeter stent and then a much larger valve in that, even a 29 sapien.
So here, the MPA measured about 30 millimeters by the looks of it, I think, and 96 kilograms. The surgeons have a nomogram, and I can't remember what they would do, but I'm guessing it's around 26 or 29 millimeter valve they would put in.
But aren't there concerns about cracking the homograft at that size? And my concern is that because there is a poststenotic dilatation, there may be some endo leak and we may not be able to salvage the patient. The concern is between the safety and long-term issues.
The more calcium there is, the more circular there is, then there is that limitation. But here, the calcium is purely anterior, really.
Okay. Okay.
The calcium,
the
is
rest of
very, the calcium is very proximal.
What?
So now I am getting both the pressures, RV and pulmonary artery. There is a good gradient. I want RV angiogram now from the marker pigtail, from the non-marker pigtail. No, Just wait for some time. Let the pressures be shown. Pressure big, hemodynamics big. Okay, now get the RV now. Angiogram. There is a 30 to 40 gradient. 24 atlas ready.
So it has more or less remained the same after your pre-dilatation, Shiva.
Yeah. Let me see the location.
Well, if you do the angiogram, that might give a clue.
Yeah, I'm doing it
Yeah.
now. Around 25 ml at 15 rate. 25 ml, 15 rate. 20 minutes. Ready. Okay. So I want a 24 millimeter Atlas Gold, 24 into 4. Can you get me the thermo wire again?
Andy, what do you think is going on?
Shiva,
Ah,
my question to you is, rather than putting another pigtail, removing the wire, why did you not put a guide catheter over that same wire which had such a great position and just take a pullback?
oh, that also could have been done. Actually, I was anticipating that there will not be a residual gradient, Bharat, because we were. One second. Let me get the guide. Get me the right
but-
coronary artery catheter.
It may be that the stent is too small.
Yeah, possible.
It's a patient stent mismatch.
Yeah, exactly. Andy,
Patient size mismatch. Yeah, come to AP view. I want to get in deeper into the one of the pulmonary arteries, and then the next step I want the same Lundquist wire again. Can you hold the wire?
Yeah,
Come
I
to
think
AP.
definitely you have to go a bit bigger here. I think 24 sounds very reasonable.
24 Atlas Gold ready, open.
Sag,
yeah.
I think that it's very important to get rid of the waste, you know.
Absolutely, yeah.
Yeah.
Correct. But that waste seems milder to
Yeah.
explain the gradient.
Yeah.
I'm going for it, Dr. Basil. I'm going for getting rid of that waste. My plan is to put in a 24 millimeter Atlas into the melody now.
Have you got 2 centimeter long or 4?
24 into 4 I want.
Oh, good. You have one?
Yeah, I have one. Okay, now get it out. 24 into 4, and as soon as I get this Lundquist inside, I want a lateral projection. Lateral projection.
Kevin, how far would you push this?
It's a melody, so you're probably limited at 24. I think it would be hard to go to
No.
26.
I think 24 is probably.
Well, you could go to 26 and then put a sapien in. No?
Yeah. You're doing
24 is the maximum balloon.
Okay,
it's used.
can you hold the wire?
24 and high pressure.
The issue is whether you would go stepwise 22 and then 24 or boom, straight 24.
Well, again, if there was a lot more calcification, then you go
Then you would probably-
stepwise. Here,
Yeah.
you're okay.
Yeah.
I want a contrast.
What do we know about this pre-stent? Is it a pretty strong stent? What would you compare it to? The Zephyr?
We
Something
don't
similar
have
to
that
something
much of
similar to
experience
Andra.
for native. Yeah. But Shiva, we don't have much experience with calcific conduits, or do you?
I have put it on many occasions.
Okay, and it remains well.
Yeah, reasonably okay. Sometimes
Okay.
you have to put in 2.
Okay.
Well, you might have to put in 2 here then. It-
I'm at 6 fluorostop. I'm withdrawing it on fluoro so that recoil can be seen.
yeah, that was better.
Not much.
And now you've got rid of the waste as well.
Let me see how. I need to deflate. I want again that marker pigtail.
Have you got your arterial pressure anywhere?
Arterial pressure, can you correct it, Tejasvi? I'll do one thing. I will do one coronary injection, and I will come out of the coronary wire. I think we probably
Yeah.
don't need this coronary now.
But I'll do the angio first, and then.
Yeah. So now this coronary can come off, including the wire, and now connect this left coronary directly to pressure.
Well, the pressure's obviously okay, looking at the coronary filling.
Yeah. Okay. Oh, just connect it direct. Okay. Fine. Show the coronary aortic pressure is good. Change it into smaller scale, like 200 scale. Now I am getting my marker pigtail deep inside. Holding. Okay, load contrast.
This is a very good educational case, isn't it? Because
Yeah,
there are
absolutely.
lots of options.
So now this is now the pulmonary artery, and I am disconnecting the aorta. This is the aorta, right? Disconnecting the aorta and connecting it to RV. Pressures are looking good now.
Internet is frozen by looks of it.
Go
No,
put it
probably
on.
there is a.
Put it on small, both on same scales. Increase the speed. Yeah. There is about 15 gradient.
I think
I will change the
Accept it.
transducers.
So RV pressure is 70,
Yeah. But see,
gradient 20. Kevin,
actually, what is happening is each time after I inject, the PA pressure slightly goes up, and after some time it settles out. Bharat, I was observing it every time. I
Yeah.
will- Okay, now. Wait.
No,
Show the pressures
I-
bigger. Pressures big screen, full screen.
Shiva, would it be worthwhile doing a pullback just to, with an end hole catheter or with the multi-track?
I will do that. First, I will make an angiogram and find out whether the melody is working. It's not. I mean, there is a gradient of around 15 millimeters. 1.5.
I think that the higher right ventricular pressure and the gradient is due to the fact that my friend said that the
Basil,
stent is really,
Basil, Michael.
yeah, the stent is really higher. The stent should have been a little lower. For that reason, there is a residual gradient and high RV pressure.
Okay, ready for
how,
injection?
Basil, how does the high
Ready?
stent increase the gradient? Or because we haven't seen the angiogram, it looks quite wide approximately.
Okay, this is the distal angiogram. The valve is working well. The valve is
Possibly there is
holding the contrast. Now I will do what Kevin was telling. Give me a wire. Get me a
Because,
7 French guide catheter.
because if it's higher, if the stent was lower,
7 or 6 also.
probably there is some of still obstruction in the RVOT.
Okay,
that-
well, we'll check that with.
But the shock, that obstruction was just about 15. I think it is okay to accept, even though it will be desirable to have 0 gradient. I'm having 15, not extremely large. I need a guide catheter.
Yeah.
Can I ask
Amal.
you something, please, Shiva? This is Amal.
Yes, Amal.
Do you have in your experience balloon dilatation of these homografts before actually progressing to valve, and what is the result of this experience, please?
Almost invariably, the balloon dilatation will result in some degree of expansion of the conduit, thereby making, in fact, I predilate many of my conduits. The reason is the passage of the larger sheets are easier. I want a 2 boost now. The passage of the sheets are easier. However, if it is very densely calcified, then I don't do that. In very minimally calcified, this 2 boost is enough. This 2 boost. In very minimally calcified, yeah, go ahead. Conduits, I will be very happy to predilate.
We're still waiting with bated breath RV angio to show what the result is like from the right ventricular end.
Okay, that will show you now itself. Actually, the right ventricle was ready. Give a right ventricular angiogram now. Come. Okay. Okay. Now, drop the table a little bit.
Excuse me, but the blood pressure was so high, 150. That's why maybe right ventricle pressure is so high. It may be exactly.
Ready?
So, Basil, where would you have put the stent lower? Use the microphone.
Yes, 5 millimeter or 7 from the
show that angiogram again.
Current position. For the current position, 5 to 7 millimeter lower.
I think that probably the position of the stent is not an issue. It may be that just the size of the stent may be somewhat smaller for the size of the patient, but otherwise I think the...
Any other comments
I'm
from
making
anybody?
a pullback now.
Kevin?
I think some of it is what was mentioned earlier, was that the blood pressure is really high, so there may be a lot of catecholamine running around, and that's going to give you gradient and RV hypertension.
I'm not crossed it. Come to AP view. I'm trying to advance the guide catheter deeper.
Yeah, Sonia.
Go to lateral view again.
Thank you. Can I recap with you, Shiva? This is Sonia from Cairo.
Hi.
You placed at first a 22 Melogy valve, right?
Covered it with a cobalt chromium stent, which was also acting like a pre-stent.
Okay, and then you redilated.
Post-dilated with a 24 millimeter Atlas.
Atlas.
Yeah.
You dilated above the valve, right? You made sure that you're dilating above the valve, or you dilated including the valve?
I will show the dilatation now. Show the previous picture.
Please do.
Yep. Previous.
Including.
Previous. Okay. That one. That is the balloon.
You're not worried about losing the valve when you are dilating with a high pressure balloon?
About losing what?
Damaging the valve leaflets. That's Sonia's question.
But in a Melody, the 24 millimeter post dilatation is well accepted, Sony. It's a common thing that is being done. Yeah, it's very safe. It's a very safe step. That advancing a 24 and okay, now hemodynamics big. Okay, I think then only we will be able to see. Now I am pulling back. I am at the level of Melody valve. So now I'm coming a little proximal. I am now just at the level of the, there is not much of gradient, just at the level of this position. I am now coming down. Actually not much of gradient, Shaq. It's all in and around that 40, 50.
Yeah, it looks all right.
Yeah.
Yep.
I don't see any gradient. And so the The last angiogram was, show me that RV angiogram. See this RV angiogram also, maybe lower the infundibulum at the place where the ventriculoconduit junction may be having, figure of eight, ventriculopulmonary junction, or at the proximal end of this bovine pericardial hood, maybe there is some subtle, but hardly of any significance.
Yeah.
Shaka, I'm moving now to the next lab for the
Okay,
second.
well, before that, shall we give you a big hand to the rest of the team as well?
Thank you, thank you. So can you get the PowerPoint presentation?